Hello, thank you for joining us for today's webinar hosted by Virtual College and Haelo on the Medication Safety Thermometer and Omitted and Delayed Medicines e-learning. My name is Craig Marshall. I'm the Service Delivery Manager for Health and Social Care at Virtual College, and I'll shortly be handing over to Kurt Bramfitt, Programme Manager from Haelo. So just a quick look ahead before we get started. As I say, I'm going to hand over shortly to Kurt from Haelo for an introduction to the Medication Safety Thermometer, and then Kurt will hand back control to myself, and I'll take you through an introduction to the National Patient Safety Suite, including Omitted and Delayed Medicines. So at this point, I'll hand over to Kurt, who can take over and deliver his short presentation on the Medication Safety Thermometer.
Thanks, Craig. I'm just going to share my desktop now with everyone. Okay, so hopefully everyone can see that now. So my name is Kurt Bramfitt. I'm a Programme Manager at Haelo. Haelo is a Centre for Innovation Improvement based at Salford Royal NHS Foundation Trust. And at Haelo we've been commissioned by NHS England to produce what is known as the next generation suite of safety thermometers. These are basically safety thermometers built upon the design and improvement methodology of the Safety Thermometer Classic, which was the improvement tool that measured harm across the health economy from pressure ulcers, falls, VTEs, and catheters, and urinary tract infections. So based on that methodology, we were approached by NHS England to commission and produce and develop this medication safety thermometer, really focusing on error of harm and harm from medication error. So the medication safety thermometer fits in line with the NHS outcomes framework around domain 5, specifically looking at the incidence of medication error causing serious harm to patients. Now this was the real challenge and the focal point of this work. So when we look at medication error, we know that a large number of drugs that cause the most harm to patients generally can slot within a certain category. So these drugs, based on incident reporting data and other data sources, usually signal that opioids, antibiotics, things like warfarin, insulin, they're the known high-risk kind of critical drugs that we know, if administered incorrectly or omitted, can cause harm to patients. These are the common high-risk drugs. Equally, when we look at the reasons for this harm, we've got a quite sort of top of the pops listed number of errors and reasons. So we're looking at wrong dose, wrong strength, wrong medicine, wrong frequency, wrong quantity. So we've got a real understanding from other data sources around the drugs that cause the most harms and the reasons for causing most harm. Now, as a data source, this has been taken from incident reporting data, and we know that the culture of reporting has changed over time, and people are becoming more confident in reporting incidents. They're being more transparent within their care and the delivery of care, and as a culture we're changing, so we're quite happy and we're confident that if something has gone wrong, we will report that, and that's good. And we've seen that increase year on year. So really looking at incident reporting as a measure, it's a good sign that culture's changing, that we're becoming more comfortable in reporting. However, in terms of medication errors, it's quite acceptable to acknowledge that it wouldn't be practical to record and report every single error that occurred around medication, because it happens in the thousands. So practicality-wise, it's very difficult to measure that. And in order to understand if we're improving, we need to understand what the process is around that. So the medication safety thermometer was kind of spawned from that concept and that thinking of how can we measure harm from medication error and how can we measure medication error to start with. So the medication safety thermometer is based on a 3-step process. So step 1 is around basic demographics and information of the patient and the kind of medication that they're on. So step 1 collects patient information, age, gender. We look at, has the patient's medicines been reconciled within a 24-hour period? We ask for the number of regular prescribed medicines that patient is on at that time. We look at medicinology status, so has the patient's medicinology status been documented and recorded within 24 hours? And then we also look at the number of omitted doses or the number of omissions that patient has had within a 24-hour period. Within step 1, we also look to see has that patient had an omitted dose of a critical medicine, so medicine that's critical to their care. this falls in line with anticoagulants, insulin, opioids, and infectives. Moving on towards the end of step 1, we ask, is any of the patients at this point in time on a high-risk medicine? High risk being, linking back to the incident reporting data, the medicines that we know cause the most harm to patients if administered incorrectly. So these are the anticoagulants, the insulin, opioids, and IV and subcut sedatives. Now these medicines are not the definitive list, and we do know that there's other medicines out there, but particularly for this development stage, we wanted to understand, is this the right measure, and are these the medicines that we can see improvement in? So certainly for now, we're sticking with this list, but locally you may choose to adapt that list and add to it. If a patient is deemed as being on a high-risk medicine, we would then go on to step 2. Now step 2 of the collection form is a trigger step. So if a patient is on one of these 4 high-risk medicines, anticoagulant, insulin, opioid, IV, subcut sedatives, you would answer a series of trigger questions. These trigger questions associate to a potential harm outcome that patient may have had from a misadministration or error of that drug. If the answer is yes to any of the trigger questions that are related to that medicine, you would then move on to step 3, which is the learning and outcome stage. This is where you would capture the learning and the outcome of harm. So to do this, you would have what we call a multidisciplinary huddle. And that basically is a very small, quick meeting between a nurse, a pharmacist, and a doctor. So the idea is on your ward or wherever you may be at the time, you try and get hold of the nearest doctor and the nearest pharmacist that may be on duty and the nurse, and then you discuss, okay, we've done the safety thermometer, this is what's come out. A patient is triggered through this because they're on anticoagulants, for instance. What do we deem this to be? Has this patient been harmed? Is it a reflection on a particular process or system? What's the outcome of that? There's then an element that allows you to record that learning. So that learning is where your improvement should start. So this has happened, we've learned from that, we're then going to go on to implement some kind of change or system change. Now what does this look like and how do you collect and submit this data? So the medication safety collection form is 2 forms. So the main form is this form here. This is step 1 and 2 combined into a 1-page form. So the top half section, which is in white, is step 1. So you can see that the breakdown of questions, the allergy status question, the medicine reconciliation question, the number of prescribed medications the patient's on. In the middle we have a kind of matrix box. So this allows you to record the medicine that the patient's on, and then also if that patient has had an omitted dose of that medication, there's a breakdown of options too. So you can actually record the individual reasons for those omissions. So the options we have are valid clinical reason, patient refused, outstanding reconciliation, medicines not available, routes not available, and patient absent at meds round. There's also a not documented option and an other option. So this really gives us a granularity in the data, so we can really cut that and understand the reasons for omissions and how we can impact on that. The bottom half of the form is the trigger questions. So if you answer yes that a patient is on an anticoagulant, then you would go straight to the anticoagulant trigger questions here and only answer those. The rest obviously would be not applicable because the patient's not on those other medications. You would answer each of these trigger questions for the appropriate medicines that the patient's on. Now, as mentioned earlier, if you happen to answer yes to one of these trigger questions, this is at the point where maybe it's at a later date, maybe it's not that point in time, but you would go back to that patient's case and you would perform what we call a multidisciplinary huddle. And that is just a quick meeting discussion with a nurse, a doctor, and a pharmacist around the outcome of that patient. So if a patient triggered through an anticoagulant, then you'd simply go to this box here, you tick the outcome of the harm that you had agreed between yourselves, and there's a box here to record some brief notes around what your learning was. What was the outcome of that? What's the learning and what's the next steps? Now in some instances you may go forward to file an incident report for that. The outcome of harm may be that it deemed it was an incident, so you would then go through your DATEC systems or formal reporting systems. The bottom of the form allows you to capture that. So you can tick to say that an incident report's been completed, and you can record the incident reporting number as well for the later referral or backtrack to understand and maybe go through and break down your learning in more detail, depending on the improvement work that you may be doing. At the top of this form, you can record the names of the people who have been involved in the huddle and the job titles. And there's also a little box at the end there where you can record whether that you were actually involved in that patient's care or whether you would just happen to be around on duty at the time and have been involved in the discussion. So different elements that help you to understand the situation and the learning that you've captured. Now, the way the Medication Safety Thermometer works in terms of submissions is you collect the data maybe on paper form to start with and then submit that at a later date through the Medication Safety Thermometer web tool. Now, this is a central website. This allows you to go online, set up your wards, your units, your staff access, and then submit individual records through this very much survey-style drop-down box. So each patient that you survey, you would add a new record for. Now, all of this data is referable, so you can go back to it at a later date. So you may carry out step 1 in the morning, then step 2 you may carry out in the afternoon with a pharmacist, or vice versa. So locally, you should really adopt and adapt how you perform your collection to whatever suits your needs best. This also allows you to go back at a later date to that patient's entry and fill out an MDT form. It may be at the time of collection that there isn't a pharmacist on duty or a doctor's not available, and you want to review that at a later date. This functionality allows you to do that. Now, the final thing with the Medication Safety Thermometer is once you've done your collection, you've collected data on your errors and your potential harms, you want to be able to view your data over time. So the Medication Safety Thermometer allows you to do that. Now, this is a high-level dashboard of acute settings, so this is all acute organizations collecting data. Now, this gives you your high-level outcome measures. We can, through the Safety Thermometer web tool, break this down to organizational level and also individual ward level, so you can actually view your ward level data for your organization and look at the difference between wards and really focus on home improvement work around where are the areas I need to improve, which one of them may be emissions. So this tool allows you to do that and track your improvement over time. We also have a non-acute split of this data too, so if you're collecting this data in the community or outside of the hospital setting, there's a separate form that collects the same data and the same measures but has slightly more non-acute friendly wording and has taken out some of the things that are acute focused. All of this data is available at the Safety Thermometer website, which is www.safetythermometer.nhs.uk. If you want to get involved, maybe you're interested and would like to know some more information, if you visit that website, you can contact Haelo team directly, give us an email, and we'll get back to you with further questions and anything else that you may be interested to know about, broadly speaking, of the next generation of safety thermometers. So I'd like to thank you for listening. I'm going to hand back over to Craig now, who will go on to speak about the new e-learning package, which will hopefully complement the Medication Safety Thermometer.
Thank you very much for that, Kurt. I'm sure everyone will agree that was incredibly interesting. And hopefully now I can go into some detail on our National Patient Safety Suite of e-learning and how that can tie into the Medication Safety Thermometer and help with the use of that tool. So thanks again, Kurt. So before we move on to the detail of the e-learning, which Kurt hinted at, just to give a little bit of background to where we fit in. So we're Virtual College, we're an online training provider. We've been in business now for 19 years and we're based in Ilkley in West Yorkshire. We have over 1.3 million online learners and are one of the top fastest growing companies in Yorkshire and have been voted one of the top 6 e-learning providers within Europe. We work with nearly 5,000 different customers each year with over 500 key accounts, some wide variety of sectors, obviously healthcare, NHS trusts and other healthcare organisations. We work with a number of councils and safeguarding children and adult boards, and indeed colleges, universities and commercial businesses. We supply our customers with a wide variety of products and services. Our main offering is our interactive e-learning. We now have over 250 courses available. These are delivered through our own learning management system. We also have online auditing tools, can do bespoke course development, mobile apps, and indeed offer continuous improvement and lean healthcare training and consultancy. So to bring this back round to Medication Safety Thermometer and our Omitted and Delayed Medicines e-learning, it all started back in 2010 when the National Diabetes Inpatient Audit was carried out and highlighted 5,000 insulin safety incidents between 2003 and 2009. The then National Patient Safety Agency issued an alert requiring all organisations to train their staff in the safe use of insulin if they did indeed handle, administer or prepare insulin for use. So the safe use of insulin and indeed the subsequent e-learning courses were developed by Virtual College in conjunction with NHS Diabetes, and these have now been accessed by over 200 and 25,000 healthcare professionals. Unfortunately, central funding for the suite ceased early this year, and the courses now make up the subscription-based National Patient Safety Training Suite. So as I say, Virtual College, we provide the e-learning expertise and the technology platform, and we work with subject matter experts in the NHS. Our main contacts are NHS England. This particular course we're about to discuss, Omitted and Delayed Medicines, we actually worked with Kurt from Haelo on some of the content for this course, along with some other contributors as well. But all of the courses, we have an SME from the healthcare sector working with us to ensure that the material is up to date and as accurate as is possible. So currently in our National Patient Safety Suite, we have 7 courses available. We have the safe use of insulin, which was recently updated to reflect some new legislation, the safe management of hypoglycemia, the safe use of intravenous insulin infusion in adults, safe use of non-insulin therapies for diabetes, the safe use of insulin syringes, pen devices, pumps and sharps, the national curriculum for the training of healthcare professionals who care for children and young people with diabetes mellitus level 1, and the safe management of diabetes during end-of-life care. You may have caught our last webinar on that last course. If not, you can view that at our website, www.healthcareea.co.uk. All our previous webinars are available to view online. So the latest addition to the suite then, Omitted and Delayed Medicines in Hospitals, as I say, developed with the patient safety domain NHS England, utilising subject matter experts from across the NHS. As we know, for a variety of reasons, as Kurt's been touching on in his discussion earlier, medicines doses are often omitted or delayed in hospital, and this can cause serious harm or death for some critical medicines or conditions. The course there is aimed at healthcare professionals who prescribe, dispense, review, supply or administer medicines in hospitals. So this course can cover a wide variety of roles and grades, so from your pharmacists to your nurses, consultants, a variety of different staff will benefit from undertaking this training. So on completion of the course, learners will be able to demonstrate an increased awareness of the frequency and types of reported incidents and harms that arise from omitted and delayed medicines in hospitals, and also describe safer practice to minimise the frequency and risk of harm arising from those said omissions or delays. So just a quick view at the lesson plan, what's actually included in the course. We're going to talk about some of the traditional errors, errors of omission or delay, working together to reduce the risk, links nicely with the huddle that Kurt was talking about. National Patient Safety Incident Reports, omitted antimicrobial doses, critical medicines, how to minimise harm, the national guidance on minimising harm, any local medicine procedures, monitoring medicines administration, and then there is a section on the Medication Safety Thermometer discussing some of the findings from the pilot sites and some case studies as well to finish off the course. Moving forward with the National Patient Safety Suite in a bit of a wider sense, we have a further 5 courses in development. These are due for release over the next few months, taking us into the next calendar year. And by the end of the financial year in April, we'll have a total of 13 courses available in the suite. Subscription fees are reinvested into developing future courses and providing the ongoing platform to deliver these courses. So the courses that are coming up in the future, we have the safe management of people with diabetes, dementia, depression and severe mental illness, safe management of diabetes in pregnancy, Get Moving, Get Healthy, which is going to be a course aimed at service users and individuals living with diabetes, the safe management of diabetic foot, and building on the current course, Omitted and Delayed Medicines in Hospitals, we're going to have Minimise the Risk of Harm from Medicines Overdose. So it's really important that people are trained in these areas, but why would you choose e-learning as opposed to a traditional face-to-face methodology for training your staff? Well, it's often cheaper to train people using e-learning than it is face-to-face training. Individuals can go at their own speed and pace. It is flexible. Staff can log in and out of the training at a time and place to suit them. If they only have 15 minutes available, they can do 15 minutes of learning, go away and come back and complete that course at a later time. It brings the classroom into the workplace, so perhaps if you do have access to a computer in your work setting, you can break away from your daily activities and do a little bit of learning in between. And it does allow you to deliver a training message across an organisation at a greater speed than perhaps face-to-face delivery. And you do know that you're getting consistent message with that, with e-learning as well. And then finally, sustainability. You can use e-learning as a way of updating people's knowledge and sustaining training that's already been done. So a good example there would be the Safe Use of Insulin course, which we've recently updated to include new legislation, and you can use that course to ensure that your staff are fully compliant in that area. It's really easy to access. We have a self-registration mechanism whereby individuals within your organisation can go and register themselves for the training, and we supply organisations with instructions of how to do that. All individuals are then given their own learner record, which tracks their progress through the various courses they wish to complete, and if there are indeed updates to courses, these will be reflected on your learner record. Feedback so far, so analysis of over 15,000 evaluations that have been completed in 2014. On the left-hand side here, we're seeing only 10% of people having difficulties navigating through the system. And then on the right-hand side, 93% of individuals undertaking one of the courses within the National Patient Safety Suite would recommend those courses to other people. So just a little bit of detail on the subscription options. For larger organisations, 12-month subscription to a site licence will give you unlimited access to all of the courses currently available for £5,000 plus VAT. And as and when further courses are added, you will receive these free of charge in with that initial subscription. 5 or more larger organisations can join together to receive a discount on the site licences, and this works quite well if you're looking to have sort of a regional deal. And indeed, smaller organisations can also club together. If you do have a number of small organisations with less than 5,000 staff, they can join together to share one site licence, making it a bit more affordable for those smaller organisations. And individuals can purchase these courses as well, so we have a sliding scale of book discounts available if you are looking to purchase on quite a small level, or indeed purchase for yourself for individual use. So the next steps then, to check to see if your organisation subscribes to the NPSS, you can go to our website, which is http://nationalpatientsafetysuite.virtual-college.co.uk. If you follow the instructions on screen as if you're going to register, you can locate your organisation on the drop-down list and continue from there. If your organisation does not appear on the list, then at this stage your organisation hasn't secured ongoing access to this training. But if your organisation doesn't subscribe, we suggest that you contact the individuals responsible for that particular piece of training. With the case of Omitted and Delayed Medicines, it's possibly going to be your chief pharmacist, maybe your learning development team, somebody who works specifically with medication safety perhaps. But you could always just try with your line manager to arrange whether or not this training is relevant for you. If they do need more information, you can direct them to our website with the link on screen, or you can contact our patient safety training manager here at Virtual College, John Thornton. John's email is on screen along with John's phone number. And again, if you are just looking to purchase the courses individually, there's instructions on our website of how you go about doing that as well. At this point, any questions that anybody has, Kurt and I will answer in the chat window. Thank you very much for joining us on this webinar today. Any questions that we don't get through, please do feel free to email them through to myself or Kurt. Thanks for joining us, guys. Goodbye.